to confirm. Got it. All right. Now it says we're live on Facebook. Let's pop over there just to confirm. There we are. All right. Folks, we had just a little bit of technical difficulties. I think what happened was the internet just could tell that we were doing a special event today, and it was like, whoa, what's going on here? We're not used to the Ask the Net Expert event. So we went back old school. We went back to our previous method of using Zoom, and it seems to be working. So we're going to get it done one way or another, and I see people joining the room already. So thank you very much for sticking with us. Today is a special event outside of our normal luncheon with the experts that we do once a month now on the second Thursday of every month. This is a special event today brought to you by Cezar Therapeutics. And specifically, we're going to be talking about carcinoid heart disease. Now, if you aren't familiar with me and the content that we usually create, my name is Rain Bennett. I will be your host. I'm not a medical expert. I'm a filmmaker and a writer. I've been working with CCF for a little over 10 years to create video content, documentaries, treatment-based videos, and live videos like the one you're going to see today. Now, some of our regular programming is very open and all topics go, but today's guest, we're kind of sticking to the topic of cardiology and carcinoid heart disease. I'll give him a chance to introduce himself in a moment. But we welcome everybody. Sorry again for the 10-minute delay, but happy to be here with you. If you want to chime in and say hello in the comment section, go ahead and do that. And in the meantime, I would like to welcome our guest, Dr. Now, he said it was okay to call him Cezar Ilescu, but the real pronunciation is Cezar. Is that right?
Absolutely.
Are you sure?
Absolutely. Positive.
All right. I like to get that right. But Dr. Ilescu, welcome to the program, Ask a Net Expert. Hope you're doing well today. For those that aren't familiar with you, tell me a little bit about your role in this neuroendocrine tumor community. Where do you work? What do you do? And how do you serve this NET community?
Thank you, Rain, and really a privilege to be here today. We've been serving, again, patients with carcinoid and carcinoid heart disease for almost a decade and a half. And it started here at MD Anderson 15 years ago. So we opened actually at MD Anderson the first cardiac catheterization laboratory in the world in a cancer center. And the design and everything was to be able to provide this sort of boutique cardiology for our patients, to be able to create new paths for diseases that are not that common. And carcinoid was one of those diseases. I call it orphan disease. There's not a lot of patients, it's not a lot of disease knowledge about it, and it's not a lot of treatment. And it started really 15 years ago when we got in this medical center, the oncology team, of course, that's leading in this effort with Dr. Yao, Dr. Halperin, Dr. Dasari, and a lot of experts in carcinoid disease and carcinoid heart disease. And then, of course, we got the cardiology team, and cardiology, this cardio-oncology field was at the time was just the beginning of it. And we got imaging experts, echocardiography experts, MRI experts, again, me, interventional experts, of course, surgeons, when we worked with Dr. Gregory, Dr. Kaur at the time, which are world experts in surgery and interventions. And we all sit together to see what the path is for this extremely complex patient that we didn't have a clear path. Now, that being said, and I have to give a little background in this field. We had a very good understanding of what we were 15 years ago from Mayo Clinic, which led the world in this effort, with a beautiful database with a lot of knowledge. But of course, this was an evolving field with evolving topics. And at the time, based on the initial experience and knowledge at the time, the field was doing things versus not doing much was almost the same because the outcomes are not that good. So we had to come up with a new path and innovations in this field to be able to serve our patients. And that's pretty much it. So we've used, again, all our tools, all our knowledge, and we look back now, 15 years later, we have a path. We're going to talk to our patients and the patients in the audience. And that's the beauty of us getting the opportunity to be part of your podcast today, is that we're going to be able to reach to other patients and spread our knowledge. Some of the things we know have been written already, and we have them online. That people can read them on PubMed and they can see them. Some of them, they're just ready to be submitted. So we're gonna find them hopefully in the next few months, and we're gonna know about those in the near future. Some of them are really dreams, and we can share even those with you. And of course, now that we have an established program and everything, we're gonna reach, throughout the country to other, reputable centers to create this effort nationwide and worldwide to move this field forward.
Understood. Thank you so much. I appreciate that, and I appreciate you being here. Folks, if you could do me a favor, anyone that you think may be interested in today's program, I told Dr. Ilescu when we talked earlier this week that lots of our attendees are interested in this topic of cardioid heart disease and or carcinoid heart disease rather, and often we don't have a specialist to discuss it. So I think this is a unique opportunity that we have, and because of our technical difficulties, I want to make sure that we get everybody here that was planning to be here. So if you know anybody that is typically here or that should hear this event, do me a favor, tag them in the comments. You can share this video with them, remind them that the show is going on, and go ahead and start sending in your questions. We're going to try our best to get to all of them. One little tidbit that I like to let people know is sometimes we're in a place where we can't play the audio too loud when we're watching these programs. So at the bottom of your viewer on Facebook, that gives you a few options, few little icons down there in the bottom right corner, and the one that says CC will pull up the captions, the auto-generated captions when you're watching this, and it just helps you kind of read while we're listening and keep up with everything, because sometimes when we start talking about some of these dense topics that are jargon filled, it's hard to keep up, and so that's a little helpful tip for you. I see everyone saying hello, and lots of people saying how hot and sticky it is all over the country. Here in the States. I'm sure it is where you are, Dr. Ilescu.
In Houston for sure.
Whew, I'm in North Carolina, and it's no different here. So, Dr. Ilescu, to start us off, I'm always kind of an advocate I always empathize with the people who are very new to this journey. Now, the net patients that we typically have in attendance in the shows are very well educated. I think that it's probably one of the more educated communities that I've seen in terms of like navigating their own disease and being their own best advocates. However, when you have someone that's newly diagnosed, it's a rare disease. They probably haven't heard of it. They're hearing things they're confused about and therefore maybe scared about. So I like to start with just the fundamentals, the foundation. So let's start from square one and establish for a newly diagnosed net patient, what exactly is carcinoid heart disease? How do we get there? What are the impacts of it? Let's just go back to 101.
Beautiful question. And there's two scenarios, of course, there are a lot of scenarios, but there are two big scenarios where we start being part of this effort. So the first one is exactly where you started. It's a patient with a neuroendocrine tumor, has no heart disease, but they want to make sure we're trying our best not to get there, because of course it complicates the course of disease, adds additional steps, additional interventions, of course, additional risk on the patient. So the first scenario is the patient is seen by the oncology team. They read about the disease. They're concerned about what will be my risk to develop carcinoid heart disease. How can I monitor? How can I watch it? And it's a good question for our patient population and even for our cardiology community. So there's a good effort done throughout the country where we have some indirect metrics of the possibility of the chance of the heart being affected. And there's two. One of them is a hormone, which is a hormone released by the heart. And it's a hormone of heart release, heart stretch, that's called NT-proBNP. And that one is usually elevated in the patients that are affected and have carcinoid heart disease. We have some cutoffs, some thresholds above which we have a low threshold to do an echocardiographic study, which is a more invasive test where we use the ultrasound technique and we see exactly if the valves are affected or not. So that will be one step. And the second one is the level of 5-HIAA, which most of the people in your audience are familiar with.
Sure.
Is again this metabolite of the serotonin that's released mainly in the urine and where we measure it. And if those levels are above a certain level, the odds of us having heart disease and heart effect are higher. And actually, by every 10 units increase in this level of the hormone, we have increased, obviously, mortality. So this is really part of our effort. This is how we started being involved and work with the Lotriset, with this new drug that you most of the people in the audience are familiar with, is because what we've seen is we had an honest discussion with the oncology team, and the discussion was, yes, the tumor is stable in size, which is true. We controlling with the long-acting octreotide, lanreotide, the diarrhea, the flushing, all the carcinoid syndrome symptoms, yes. But why is that then the lifespan of the patient is not normal? If the disease is controlled, why then, of course, in a situation where we're controlling the disease, why the normal patient's lifespan is the same with a normal patient that doesn't have the disease? So then we thought, and we pushed forward the field with our oncology team to where we thought that maybe lowering this level of 5-HIA in the blood or in the urine to a lower level, of course, that will translate in less stretching on the heart. And in the end, they're less likely to have the heart affected by the disease. And so this is a new paradigm we're introducing in the field, to where we're trying to push whatever we're doing right now, the standard of care, further down. So we're trying to roll the dice in this direction to where we're lowering to the most we can, with the hope we not having a lot of side effects, with the hope we're still improving the quality of life of the patients. But on top of that, we're hoping to increase the lifespan, which is the most important thing in this, really relatively young patient population. We're talking about most of our patients, in the mid-60s, but the reality is that we had patients in the 20s. And again, we had patients in the 70s, mid-70s, which are less likely candidates for surgical procedures and more aggressive interventions, because of, additional frailty that we expect to have as we get younger.
Well, what exactly are some of the typical symptoms?
Okay, so this is the majority of our patients, that present is actually, and it's a beautiful case. We had the privilege to present this nice case at one of our institutional research meetings, and actually was awarded one of the institutional research awards, one of our research fellows, Dr. Abdel Rahman Ali. But the bottom is, it's very intriguing. We have the patients do come, of course, with diarrhea. That's the main driver. Usually that's what bothers the patients, with carcinoid syndrome symptoms. So now, in depending on the patient population, the diverse background that they have. For example, you have the minorities, the Hispanic population here in Houston, really prevalent. Also, a lot of diabetes associated with the disease. And a lot of patients are, for example, on metformin, which is a common drug, for diabetes. But guess what? It can be associated with diarrhea. So the patients are young patients. They present with diarrhea. We think it's from metformin, but nobody thinks about what about, it can be metformin. What about can be carcinoid, disease? So this is where we have some delays in diagnosis, delays in care. And in general, people do have delay in care. We're looking between 1.5 years to 2 years, where this diarrhea is just medically managed and nobody thinks about neuroendocrine tumors. And then in the end, by the time we do these CAT scans, we see obviously the disease, the low primary disease, usually at the time metastatic disease. And in few cases, 1 in 5, we already have at the first time of diagnosis heart involvement. And this is the second case scenario. So the first time the patient sees the oncologists do a very good thorough physical examination. They hear a loud heart murmur. And then this, triggers evaluation by cardiology. Also, when they do the CAT scans, which is standard evaluation, sometimes they see what's called a dilated inferior vena cava. So one of the veins, the major veins that comes to the right side of the heart is dilated because of this reflex that comes back and basically makes the vein larger. And they even can see this contrast flowing back in the liver. And again, it's another indicator that this is an issue and it's a possibility of the heart being affected by the carcinoid at that time. And this is the second case scenario. And we had the interesting research was hemodynamics based, where we see these patients for the first time, the patient, instead of having a huge challenge with carcinoid disease per se, has on top of that this additional challenge, which is carcinoid heart disease. So we're facing two big issues the first time they get diagnosed. So instead of having a big mountain to climb, it's a Mount Everest to climb. And this was the first feel we got, is like, how are we able to solve this, not. And we thought that cardiology were the privileged ones, in the sense that we have all these tools, all these advanced techniques and everything. And again, through hemodynamics assessment, we're able to triage the patients in 3 groups, a group where we have the luxury to still watch the patient, to let the oncology team have, a few months, 3 months, 6 months to treat the disease, to obtain control of the disease. And then, of course, after that, have this surgical procedure again. When the heart has the valves affected, it's a mechanical problem. And it's unfortunate that today, as of today, we have only one mechanical fix. It's you have flat tires, you need new tires. So you cannot drive the car. So we have, again, 4 heart valves. We have, again, traditionally, we have 2 flat tires on the right side. So it's the front and the back valves on the right side of the heart. And again, we need to put new tires. Now, joke aside, we do not change tires, seasonal change of the tires, and we do not change those tires, more than maybe once, maybe twice,
Right.
lifetime. So we're very concerned about when we do this, we do a procedure. We've started developing very clear indication on when to fix. And then when we fix what we've learned through our efforts, and again, it's a thing that they've been written by the Mayo team almost 2 decades, but sometimes that history gets forgotten and has to be reinvented, So we're raising awareness through our efforts and our publications as well about the pulmonic valve, which is forgotten. So we have a tricuspid valve in the back and a pulmonic valve in the front. So the story is the blood comes from the liver, and it's like this room has 2 double doors, one in the back, one in the front. So the back door opens, the blood comes in the right side of the heart, the right ventricle. That one starts squeezing, and the unfortunate thing is the back door is absolutely frozen. So the back door, because of the carcinoid and serotonin, is not closing completely the way it's supposed to be and hold the blood in this cavity. So it's frozen like this. It's wide open. We call it is really pathognomonic. So anybody who sees that once can diagnose the disease. And then all the blood in the squeezing effort backflows in the liver. And what happens is the liver is usually affected from the disease. So we don't have like a full liver functional. We have maybe half of it. The other one is occupied by tumors and metastatic disease or primary disease. And you imagine all this backflow that gets the liver even more congested. And we've seen in time, how long can the body tolerate this congestion? It's not forever. Of course, the liver in the long run starts being dysfunctional. Some of the jobs that the liver has supposed to do, one of them is, synthesizing albumin gets incomplete. And then the levels of albumin go down, and then we have this spiraling down of the patient. And that's part of our understanding, is that when we get to that point, we may have lost the battle, and the indication for the surgery and for the procedure to put new valves in is already late. So we're trying to move this moment when we have to pull the trigger and make the decision to fix, traditionally, again, both tricuspid and pulmonic valves, or 2 valves at a time. Very important for our patients to ask this, how about the pulmonic valve? Is it affected? It's very difficult to diagnose on echo. And I can go into specifics forever, but it is not easy. So it's challenging because of the limited forward flow. So then, yes.
Got it. Before I start taking questions from the audience, I had just one more question from me. If a patient has carcinoid syndrome, do they definitely get carcinoid heart disease? Or maybe the question is, what is the percentage of people that develop carcinoid heart disease if they're experiencing carcinoid syndrome?
So the answer is usually, depending on who you read, 1 in 5 to 1 in 2. So it's between 20 and 50%. So it's just a little broad spectrum, but again, it is very likely. 20% these days is high incidence.
Yeah.
We used to call in the past high risk, 90%. Bad things happen these days. 10% is already high. So we're talking about 20. So it's a good chance of this happening. So the more we control the carcinoid syndrome symptoms, the more we level this level of serotonin in the body to the minimum, the less likely it is to cause the carcinoid heart disease. And this, again, is part of the stellar heart study that we're doing and everything. So we believe that the lower we get the level of hormone in the body, the less likely is to get the heart affected. And hopefully by having less heart affected, probably the heart is one of the most sensitive. If you ask me, one of the biggest sensors to get control or not control of the disease. And I'm going to go through this, but we had a very interesting study we just published early this year, where we looked at patients where so again, we talked about this. We cannot fix these valves all the time. So we had a patient population where we fixed both tricuspid and pulmonic valves. And we monitor them like hawks. Like every 3 months, the patient had an echo. We got, this hormone BNP stretching. We had some levels of 5-HIA monitoring them just to see in which one we see a trend towards valve deterioration. And it's very, very surprising to me, and it's actually very novel. So what happens is when the patient has no diagnosis, so basically his patient is back home in the community, the level of hormone in the body is so high, so he gets to the heart. The first one that it sees is the tricuspid valve. So the first valve, and it's the first one to get affected because the level of hormone is very high in the body. Then, of course, the next valve in line is the pulmonic valve. And that now this is the time for the second one to be affected, the pulmonic valve. And then, of course, this hormone goes through the pulmonic circulation where it gets inactivated in general. And then it goes to the left side of the heart, the mitral valve and the aortic valve. Those valves do not get affected often, unless the patient has a small communication between the right heart chambers and the left heart chambers. And again, that's a very good question for our patients in the audience. If you're followed by a cardiologist, make sure they do a study. It's called with agitated saline, with bubbles, we call them, to make sure there's no shunt from right to left, to make sure that, in case you get some valves affected, you don't get all 4 of them. So because if that's the communication, the odds of getting, or patients that have metastatic disease in the lungs, of course, those are more prone to get also left-sided affected. So again, it's a very comprehensive study. We do echo, we monitor all these things. But back to the story. So we got both valves, the tricuspid valve and the pulmonic valve. So we start watching them. We watch, and get interesting is once we had the valves replaced, these are not patients that have not been not treated. These are patients that are on treatment. They've been seen by oncology team. They're on long-acting somatostatin analogs. So because of that, the level of hormone is lower than it would have been in a normal situation before they got diagnosed and treated. And in that situation, it's interesting, the first valve that gets affected was the pulmonic valve. So the further down valve. And the reason is now the valve is open, it's a brand new valve, the blood gets in and it's like low pressure. Then when the heart's squeezing, the pulmonic valve is the one that sees the turbulent flow with a little bit of hormone is enough to mess up that valve. And what we've seen is when the velocities went up across the pulmonic valve, we started the medication based on the disease burden. A lot of disease burden, we started distillotristat. A little bit more burden, we did other treatments like PRTs or liver embolization, and we saw stabilization of the valves, which is why this is how we got the idea about maybe suppressing the level of hormone to almost nothing would prevent further deterioration of the valves. So these patients we talk about, they're fine. They have no symptoms, but we saw the signs of heart being affected. And by that one, we started this bidirectional process. So in the past, the oncologists were reaching out to us. Now, based on the heart and echo report, we're reaching out to them and trying to influence the disease and the way it's managed based on the heart and these early signs of maybe not achieving perfect control of disease.
Got it. Thank you. I appreciate that. Susan in the audience, I'm not sure what she was speaking to exactly, but said great explanation. I just wanted to plus one that you've been explaining things in a way that I can understand. So that's helpful. We got a lot of questions coming in, so I want to go ahead and make time for some of the people in the audience. And we'll start with Sarah. And I think this is apropos of what we were just discussing. Sarah says, I have high serotonin, 17,000, and a heart murmur. What do you suggest my next step should be?
So obviously it's a team approach, and that's why we have this complex teams and everything. So the first one, of course, to reach is the oncology team. So when the serotonin level is high, it's probably the disease is not controlled appropriately. That's one part. The second one, so that's the high level of serotonin. With a high level of serotonin, of course, we have a higher chance of having the heart affected than when you have a murmur. You need to see an echocardiography specialist or a cardiologist to do a special echo and focus to see how deeply the valves are affected. Now, that being said, is of course, we're always willing, again, whoever's close to us, whoever wants to fly to see us, we're always welcoming. Again, they can come and see us here at MD Anderson. We have a nice setup where we can assess all those things and do it really timely. So, but that being said is, so it needs both an oncologist and a cardiologist to see you. And again, Rain, you can put my email over there and everything. Again, we're serving all of you. Again, we're privileged to do that. So they can send me emails and I can reply back to you based on what you find, what would be the next step. in our opinion, to go forward.
Got it. Well, we appreciate that. And folks at home watching or wherever you're watching, we pinned Dr. Ilescu's information at the top of the comment thread. So you can just scroll up to the top and you'll be able to see that. Thank you for that. That's gracious. Polly says, my gastric level is 1700. What should I do?
Again, the disease, that's what they call neuroendocrine tumors, is
Yeah.
they release different levels of hormone. Again, and based on that, and I'm going to defer that to the oncology team,
Mm-hmm.
they're very good about understanding. Again, it matters where the primary tumor is, if it's located in the pancreas, if it's located in the stomach, if it's located in the gut, in the ileum or jejunum, and based on that, they have different characteristics. So they secrete different types of hormones, and based on those, with that, the odds of having the heart effect is a little bit less.
Mm-hmm.
So from that perspective, from a carcinoma heart disease perspective, of course, is favorable from our end. But of course, our belief is that the lower the level of hormone, the better it is. So again, I'll reach to the oncology team and see if that's acceptable for that type of tumor, because they have the pathology and everything, or the care needs to be escalated.
Got it. So Sarah asks, when a person is first diagnosed with NETs and they begin receiving treatments, lanreotide, PRRT, other medications, and they've had baseline testing of the health of the heart to determine the health of the heart, how long is it before heart health problems may begin to show up, typically?
So again, different teams around the country did a great job in monitoring. And it's difficult to sometimes to have an echo in an oncology clinic, but if they follow the level of 5-HIA or the BNP, those are good markers. As long as those are low, the odds of you having the heart affected are lower. So then we just keep on monitoring those. So whenever you see them, they check these two levels and then they watch it. Now, that being said, is in our group, we have a low threshold. We have a phenomenal echo team and expertise in this field. So we have a low threshold to look again. And it's not unreasonable thinking about the complexity of the disease and the importance of not having these valves damaged to have, on a, relatively scheduled basis, this echo imaging to make sure we're not missing anything. Of course, we've seen extremes. And we've seen extremes, where patients, we thought we have them on cruise control, and then we brought them back in a year. In a year, we had a lot of valvular disease because we're not checking systematically these levels of BNP and 5-HIA at those times. We've seen even 2-3 months, changes in dramatic in disease and everything. So your symptoms driving everything. Like if you feel you're okay, it's very likely everything is okay. If you're feeling like, the disease is not controlled, you're getting more fatigued, you're getting more tired. And in general, patients are super resilient. And that's one of the problems we're having. You're all nice people. So you're not complaining. So, people just say, oh, I'm just short of breath because I'm getting older. I'm short of breath because, I'm getting deconditioned because I'm not exercising. No, you're not supposed to be short of breath. So when you have those symptoms, low extremity edema, the legs start getting swollen. Sometimes even the belly starts getting full. Sometimes we can see some here veins in the neck being distended, being prominent. Those are all signs and suggestions, of course, of something happening. Usually it's affected the right side, so the shortness of breath is part of a bigger picture and not really just usually it's not the main driver, but it's there as well.
Got it. Thank you. And thanks for your question. Next question comes from Donna, rather. Donna says, I understand that my team recommends an echocardiogram periodically to monitor heart function, but what can I do to avoid cardiac disease? So far, I'm fine since being diagnosed with a NET 16 years ago. Thanks.
So again, there's not much we know that the patient can influence the outcome, in fairness. So it is not, as of now, we do not have any knowledge to where your diet or what you do modifies outcomes. But I can tell you this, is we had this revelation after almost 15 years being in this place one night that, cancer and cancer treatment are professional boxing. And I said, why is professional boxing? And I said, it's professional boxing because you get hit, not friendly, from the disease and from the treatments sometimes. And then the question was, after I had this nightmare, really, and after 10 minutes of living this one, I had this revelation. When I grew up, I'm from Romania, so people can guess after my last name. one of the biggest events we had, was a communist country, but the communist leader liked boxing. So we're seeing, Muhammad Ali, Cassius Clay boxing. So then I said, you'll see, this is who wins in the professional boxing. So we encourage our patients, we say always, you need a little bit of cockiness, even if the one in front of you may seem twice bigger, and sometimes he was fighting people who are twice his size, you have to have this cockiness that I will win. So, and that's what the first thing we tell our patients, you have to have, the faith that you're fighting and the little bit of cockiness that you will not be overwhelmed by what lies ahead. But the second one is to be able to absorb initially some hits, and after that to hit back. And then hitting back is this cardiovascular fitness that we keep on encouraging our patients to have. You have to be fit because you never know what challenges lie ahead. So you have to eat well, sleep well, and exercise. Now, again, with carcinoid, it's a little tricky because, of course, when we do higher level of exercise, of course, we have higher level of hormone release. And some of our patients, when they exercise, they get a flushing and limits their capacity to exercise. So we really reach to each patient individually and try to customize an exercise program to where they can push gently, but without hopefully increasing the level of serotonin, because that's exactly what we're trying to prevent, from happening, and then not help, but even worsen what happens. So it's a balance, but again, we encourage people at least to walk, to exercise at with low to moderate intensity at least, and then try to stay as fit as they can again.
So Donna, you heard him. You need to start boxing. Pick up boxing as soon as possible. And you know what? I used to teach boxing, so I can help you with that. I do have to say the walking is the oldest and most effective form of exercise. And, as a younger man, which I think happens often, I would think you'd have to do like super hard, workouts, but walking is just so good. I think it's such a great exercise. So definitely +1 to that. I appreciate you mentioning that as well, Dr. Ilescu. I see a few people sending laughing emojis, so my joke landed. So that's always good too. Dawn has a good question that's kind of the opposite of what we've been talking about. So the question is from Dawn: is serotonin always elevated with carcinoid heart? Is serotonin always elevated with carcinoid heart disease? And the real question is, so is it possible to have the heart affected if you have normal serotonin levels versus we've been talking about having super high serotonin levels?
So beautiful question. So the question is, in what moment is this measured? Should the patient can come with at the time of presentation or already with carcinoid heart disease? And then, of course, on treatment, the level is lower, and then we may have almost very, very low dose, low levels of the hormone, but the valve already got affected. And we do not have a good understanding of once the mechanism of valve destruction starts, if it perpetuates or it helps. And this is a good question. And we do not have an exact feeling of what's happening. We feel that once the timer is on and the valve starts deteriorating, it's just probably a little bit of the irreversible process. But the question is, how much can we slow it by controlling the disease? And that's a good question. And we do not have those details on that. But the bottom is, it's very unlikely. It's very unlikely. That being said, is if you start with normal heart and we start treating you the disease and you have no effect, if your serotonin level is low, the odds of having the heart effect are very low, very low. We've not seen many where the disease was perfectly controlled and nothing happened. Usually what happens is the disease is controlled, as most of our patients, for 15, 16 years. And then something happens and there's this little change in the nature of the malignant cells to where they start evading the control mechanisms we had before, and then that starts secreting more hormone, and that kind of bypasses our defense mechanisms and our current treatments, and that's when we start having the valves affected. And this is again where it's the part of our research is we have this bimodal response. Some patients we have good control, they're forever on this medication and nothing happens. And when is this timer changing? And again, it's just by close monitoring. That's the only way we're going to answer those questions. We start getting a feel again with a BNP, with the 5-HIA, we get the feel when those start getting up that the things are happening. The more abrupt this thing happens, the more abrupt the valve disease is going to happen. The more gradual, then we have the luxury of time to where we can act upon it and hopefully stabilize the disease and prevent further progression.
Got it. Thank you. Speaking of BNP, we have a question from Lisa. Hi, Lisa. Can you explain what BNP is and how it is used?
Yeah, so it's called brain natriuretic peptide. It's so in late terms is like it's basically when the heart gets stretched, this hormone gets released. So now that being said, is we use it specifically for heart disease, and when it's up, we believe the heart is being stretched and it's not functioning normal. That being said, is it's not only in heart disease, and it's a little bit non-specific. In a cancer patient population, it's part of the things we've been intrigued for the last 15, 20 years. Is it always because it'll be non-specific, like in a lot of cancer patients, this is increased without having any heart stretching and any dysfunction at that level. It's from infection, from the kidney function not working appropriate, and we have a little higher levels of the hormone. So then all of a sudden we have too many things happening and we don't know which is driving it. So, but the bottom is we do another form of invasive monitoring is a device we're putting, which is called CardioMEMS. And when we use that invasive monitoring, to our surprise, this BNP actually correlates reasonably well with heart stretching in a patient population. So it may be higher because of disease and the cancer and everything else. But if it goes up, that's bad because you have to keep it at lower levels. So we can do trends in the end. So even if it's high in a non-specific way, the fact that if it would go up more would raise concern and would trigger additional monitoring on our end.
Got it. Thank you. From Grace says, how often should the doctors order an echocardiogram, and is that test enough to monitor the heart for someone with high 5-HIAA and chromogranin levels?
That's a good question. It's a good question. We're watching them in the past when we had concerns about this one and not the appropriate control. The first group of patients we're alternating echoes with MRI. So we're doing an echo now and an MRI in 6 months, an echo now and MRI in 6 months. And we're watching them, and some of them we could catch early valve deterioration. But that being said, again, the typical approach right now is just there's nothing on the guidelines to suggest that you should do this echo more often. So it's unfortunate right now we do not have that knowledge. So it rolls back. As of now, the standard would be just the levels of the hormone stretching that I was telling you about, and nothing else. So only when those exceed a certain threshold, we talk about 200, mid 200s, then it triggers an echo evaluation. So I think that you'd, especially if people are concerned about the disease, based on the where they are located in the country, we're able to refer them to, of course, a center of excellence where this thing is done is probably more systematic, and people have the knowledge to watch it. I can tell you this is there are little signs we see on the echo, which can be missed. So we're looking, in a normal patient population, you look like, for example, I have your rain in front of me. So I look at you and I think everything is fine. So I'm going to just look, and if I don't see anything major, I'm going to say you're fine. You know what I mean? But that being said, is in carcinoid heart disease, like the same with radiation heart disease, we see like very little valve thickening, little leaks where they're not supposed to be, some changes in relaxation patterns. So we see some little early signs of something happening. And when you look for them, you find them. And that's we've seen that it's a developed skill. You're watching these early signs and to see them. And then, of course, we escalate care in that situation. So again, some people, of course, in carcinoid heart disease, people are worried about severe tricuspid regurgitation, severe pulmonary regurgitation, but there's a whole spectrum, from like really mild to moderate, and all this process and the way they evolve and how we watch them. And based on, initially, if you have nothing major, we probably watch you once a year, if the levels are high. But if we see, in the moderate range, again, we monitor them really every, 6 months. And then we discuss with the oncology team ways of escalating care to where they control the disease with more aggressive treatments, more than the traditional octreotide or lanreotide.
Got it. Thank you. Another question from Lisa. This is a good question. Can any NET patient get carcinoid heart disease, or is it only a certain type of NET that generally leads to it?
Excellent question. Excellent
Mhm.
question. There's we've learned over the years, some of them are more likely. So the distal ileum and cecum, so the gut are more likely to develop this one, while the pancreatic ones are a little less likely. But that's probably the whole spectrum of what we know right now. You know, in general, all of them have a small chance of having the heart affected. And majority of them we check and we monitor them. But again, probably I would say the pancreatic one is a little less likely,
Okay, thank you.
unless they have
Uh,
secondary liver determination, and then all the bets are off again.
got it. Next question comes from Shane. Can having multiple open surgeries over time impact the heart?
It's a very good question. So you'd say, how about if the patient had the prior surgery before? Of course, every redo in any surgery is challenging. So it adds the morbidity and mortality of the procedure. That being said, it's a great question for me about the valves. So we had several discussions, you know, if you were to have the valve fixed, how would you fix those valves? And the first question is, you know, these days we have all these procedures, percutaneous valves, and then you have, of course, open heart surgery valves. And I'm an interventionalist, so you know, my first reach to would be, how can we put percutaneous valves so we don't have to open the chest? So do one of those standard valves. We go from the groin or from the neck, and we drop those valves. But the issue is this. So what happens is, because this carcinoid heart disease, the valves are not closing, it's a called high volume state. So it means there's a lot of volume going back and forth to the right side, and the right side gets big. So imagine this normal size would be, let's say, imagine like this size, and now the right ventricle is this size. Of course, we're going to have to fit a valve this size in this ventricle. So then this ventricle is condemned forever to be large size, so you can never remodel. So that's the issue we have right now with the standard valve, is we cannot tighten up. Of course, we have some annuloplasty rings. We can go percutaneously and do those, and then this, and all of this is a super complicated procedure technically. To do it percutaneously, when for the surgeons, they can come in, they can sew a small valve, tricuspid, a small valve, pulmonic, not that small, as big as possible, pulmonic. And then, of course, this ventricle remodels and we had in our study that's published, the ventricle remodeled beautifully. So we have a normal sized ventricle, normal functioning ventricle immediately. And then in the long run, it's a beautiful experience, and we a nice effort from the UCLA team and Dr. Young with the IR group. So basically, that you can put a new valve in the old valve, because that's once the annulus is small, we can put a new valve in the old one. So if something happens to those valves, we can put another one in. So it's just few of them they've been done in the world, valves for this indication, because we're able to now to control the disease, and we're so close to the patient and monitoring them to where it didn't have to be done again. But there's an option. So once you have these new valves with tight rings, all bioprosthetic ones, we do not use mechanical valves for now. And the reason is the mechanical valves need blood thinners. These patients have what's called hepatopathy, so the liver is not working fine. So they sometimes need interventions in acute setting in the abdomen for increasing tumor burden, tumor reduction. And then, of course, you have to stop the blood thinners, and it's a whole roller coaster of managing those valves. So our experience is, the questions are, should you fix the valve? We have some indications. Which kind of valves you should put in? We go with bioprosthetic ones. We keep them on blood thinners usually 3 to 6 months, and after that we can back off on the blood thinner again to allow the patient additional care. And then we monitor them closely with echoes every 3 months. Once the valves are new, the new valves are in, then forever. So indefinitely. Once you get new valves in, the schedule is super simple to us. We check you every 3 months, 4 months the most, and we check all the levels in the blood and an echo. And every sign we see of increased valve velocity, we have indications where we talk to the oncology team, we have their input, and they make the decision. So the oncology, of course, treatment is driven by oncology team, and you have to have this again. It's a good story. So when I started over here at MD Anderson, they asked me, it says, cardiologists, you always prima donnas. So how are you going to feel in this place, you know, where you may not be the prima donna, you know, because, and I will tell you this, after all these years of working, the reality is the outcome is driven by the cancer 90% of the time, even more. So cardiology, we're so blessed. We can, and we wrote for those that read Cath Lab Digest, which is our, you know, everyday paper. we wrote a very nice article over there. We say we basically able to annul the cardiovascular mortality and morbidity. We have the tools to make it disappear. So the biggest issue is still the cancer. So we don't want to cloud anything else. So the oncology team is making all the calls. So we have one chef in the kitchen. We're disciplined soldiers. We work with them. They make the final call. So we reach out to the oncology team. We present all the situation. We present what we're finding and our understanding of the disease. And then the oncology team makes a call. And then again, we execute based on the decision made the oncologist with the patient. So in the end, you all, in the audience, the patients, we're serving you all. So we have a physician plan that reaches out to the patient. The patient decides and gives us a green light to execute whatever needs to be done.
Got it. Next question. Could you explain the clinical trial that you mentioned with Zermello?
Beautiful. So we talked about this. So we started really 15 years ago. So 15 years ago, when we put these new valves in, we monitored them really, really closely. And we saw in some patients, the velocities across the pulmonic valve were going up. And then we had this feel that despite the fact that the tumor burden was not changed and the carcinoid syndrome symptoms, diarrhea, flushing were controlled, the patient still has some progression of the disease. And I call it a drop of poison. So every day you're getting a drop of poison in the body, and it's not enough to kill you today, but it's going to kill you in a shorter time frame than you'd like. So then what should you do for that? So the only thing we could think is just to lower the level of this, serotonin in the body, because that's the poison. So maybe least poison you have in the body, the better you are. So then we looked at the drugs we have, and of course, they're different. There's a whole spectrum of disease, and of course, the oncologists make the call the way I mentioned. But we felt that the easiest way in this process is to use the medication, which is this telotrestat, which is an inhibitor on this pathway of serotonin, to where the serotonin is less produced and the levels drop. And our belief was, if we get the patient at baseline and we get the comprehensive evaluation, we do an echocardiographic study, we do the 6-minute walk to see what the functional status is. We talked about walking. So it's very important to see how much you can walk, because, normal people should walk, anywhere above 400, meters in a certain interval. So then we check the level of BNP, the heart stretching, and we check the level of hormone, the 5-HIA in the body, in the serum to be more accurate. So this is the baseline. And then we start this medication, telotrestat, and of course, we were encouraged and we were very optimistic, but of course, to have science, it has to be double blinded. So we do not know, what patient is going to get, the fake pill, placebo, or the real medication, the telotrestat. But long story short, we're going to have 2 arms, and we have 60 patients, and then we're getting almost there. So we're excited, we're getting close to, I think we reached 50 today. We're trying to reach 60 in the whole run. So again, people that are interested in being part of this study, again, they're welcome to reach out to me. Again, that's my email. You reach out to us. And again, we'll be delighted. We have 10 more spots. So, and basically we check them at baseline, at 3 months, and at 6 months. And my goal is to see there that the level of hormone is lower, the level of hormone stretching is lower. And we believe at that one, we have encouraging data to where we maybe, our goal is to recommend in the future to where you not be only on lanreotide or octreotide, but you also be on this telotrestat, which will hopefully control. Of course, it's already FDA approved, helps diarrhea. So it's going to help a little bit better with the diarrhea, but also you heard the questions in the audience will help you prevent getting heart disease. So additional headaches and additional complications. And in the long run, hopefully live longer, because that's the bottom. The bottom is, and honestly, I started here 20 years ago. And I remember, I'll tell you a nice story. It was a different disease, was leukemia. So I came from Romania, and the first time I'm here at MD Anderson, working with one of the, basically, really the gods of leukemia, like a huge Dr. Kantarjian, which is an institution in leukemias. And we saw all these people from all over the world. And I saw leukemia, and he was calling me back, said, see you back in a year. And I said, we did the same thing in Romania. We're calling people back in a year, but we knew they're not going to live 3 months, but we had nothing to tell them, and we couldn't destroy the optimism, and the hope you're going to fight the disease. But it was, and then we had people that come back a year later, and they looked unchanged. They looked fantastic. And I said, what's that? And there was a drug that had some numbers on it. And guess what? Is there was a drug, was imatinib that drug, and that basically controlled the disease. And we have now here patients I've known for 22 years, 23 years that come in here with the disease control. They just take a pill a day and that's it. They have no disease. So why I'm telling this is a message of optimism. You know, in the past we had nothing. You know, each disease had a page. Once you flip the page, was another disease. We didn't have treatments. Now these days, we have again an exponential number of drugs that come and treatments. They come every day to address the diseases you have. And the whole field has changed to where we're treating diseases to where we're treating targets. And this is the advantage of this medication as well. It treats targets. So guess what? The target that may treat the brain cancer may be the same target that treats carcinoid. And out of a sudden, we have a drug we can borrow from the oncologist, you know, that treat brain tumors and use it for patients that have carcinoid disease. And out of a sudden disease that's, again, we have limited options today. And we have telotrestat, PRRTs, liver embolization. We have other drugs, you know, everolimus and all the other treatments you know about. But the bottom is, you know, we may have another one that comes tomorrow, which is the target for the disease we're having, and we'll treat disease. So the goal for us is to deliver you all tomorrow in good health. We talked about this one in cardiovascular fitness. So in great shape, with great morale, and get you ready, because tomorrow we're going to have that drug. There's no doubt in my mind. And this is our motto. And it's not just to be a motto. It's our belief to really control the disease.
Dr. Ilescu, do you still have a few more minutes?
Always.
Okay, just since we started late, I was hoping to make up for that 5 or 10 minutes. Thank you very much. We have a few more questions we can get to. Ajid says, can a heart ultrasound provide useful information for carcinoid heart disease?
Absolutely. That's a standard. It's a standard. So again, low threshold to look, low threshold. And again, it has to include, again, we talked about agitated saline to make sure there's no shunting, no communication right to left. And also it has to be focused besides the tricuspid valve on the pulmonic valve, again, which is, again, if you imagine this is a low pressure circulation. So normally the back door closes, the heart squeezes and the blood gushes through this pulmonic valve. And of course, when it's normal functioning system, the velocities are high and you can see any glitch in it. But you imagine that the back door is so wide open that when the heart squeezes back, half of the blood goes backwards. So barely goes forward. So then you don't have barely moving. So of course, that jet, you're not going to see turbulence. You're not going to see those jets. And the valve can be dramatically underappreciated. And that's why we have a low threshold to the MRIs to see better this valve. Or really, if you were to go, and it's again, we have a nice paper on this called the forgotten pulmonic valve. If you were on a surgical table to have the tricuspid valve replaced, make sure that the surgeon opens and looks at the pulmonic valve to see it's a visualization of the valve. And if the valve is affected, it needs to be replaced as well in the surgical procedure. Again, based on the amazing Mayo Clinic work and data, we knew this 20 years ago, the odds like 80% of the pulmonic valves are affected. And when we looked in our beautiful study we published earlier this year, it's a positive trend. So it started maybe 2017, 18, maybe like 20, 30% of the pulmonic valves got replaced, and 40, 50. So it's an upward trend through efforts like RAINS, which is amazing. And, you know, to get this message out to the people, we and of course, you know, publications and efforts, people are more aware that this valve needs to be addressed as well. And that's very important for you all to know that. So it's tricuspid, everybody knows it, everybody can see that. It's obviously, but what about the pulmonic? That's the question. What about, is there a PFO, a patent foramen valve, this communication to have this shunting? So these are the questions, you know, that everybody sees a tricuspid, you know, and once you've seen one, all of you, you know, maybe one day we're going to do a podcast, I'm going to show you one valve, you're going to know how that valve looks, you know, but how about the others?
Absolutely. From Effie says, can you talk more about impaired relaxation? And then she says, left ventricle, if that makes a difference.
It's a very good question. So that's a good question. It's a very complex question. So first of all is, of course, the fibrosis. So this process of healing from this inflammation driven by the serotonin, the healing is through fibrosis. And that's why we have this pearly. If you look online and you look Google, you're going to see this pearly, the little fibrosis nodes or really bands. And obviously this fibrosis impaired relaxation. So part of the heart squeezing, the most important mechanism and the most sophisticated is the relaxation. So when the blood comes from the lungs, the left ventricle relaxes fast, and the blood gets aspirated in its vacuum in the left ventricle, and that's 2/3 of this process is driven by this relaxation, and then the heart squeezes, and then the blood goes forwards. Now, that being said, if this fibrosis is very impressive, the relaxation is suboptimal, and then the blood backflows. Now, the question is, which is very complex, is where is it coming from? Sometimes it's just aging. So as we all get younger, we all get stiffer, and then stiffer means, joints, knees, shoulders, all those things, but also the heart. So there's a process is part of aging a little bit. There's some people that have no issue with relaxation ever, but some do get it, especially when they have cardiovascular risk factors, hypertension, all those things. They kind of a little bit drive this relaxation issue. Obviously overweight, metabolic syndrome, all these things impair this relaxation. So this relaxation can be driven by other things, but can also be driven by carcinoid. Now, that being said, is to have it driven by carcinoid, the disease has to be really dramatic, especially on the left side. So it's very unusual. So it's not the common thing we see. So when we see it in general, it's mainly driven by other risk factors that are correctable. Hypertension, hyperlipidemia, again, overweight, all those things that you can work on to make them happen. And as we adjust those, there are a lot of studies out there showing that when you do those changes, the heart still is dynamic and it changes back to normal. So it's not a irreversible process.
Got it. Probably time for one more question. We've talked a lot today about serotonin. So Bernie says, how do we measure serotonin levels? Is it simple blood tests? And what steps can be taken to lower the levels?
So we discussed about this one. It's the 5-HIA that we're checking. And then the 5-HIA can be determined in the urine. It's traditional way. And it's the most accessible way throughout the country to do it, where you do this urine collection for a day, and then this urine is reached to the team, and then they send it in the designated labs in the country where this level is determined. It's not every lab, but then we do it in the serum as well, and that's part of the study, and it's going to be part of this validation process where it can be determined also in the serum, so in the blood.
Got
it. Again,
well,
not every center can draw it, so it's a little tricky question. So again, based on the part of the country you live in, we can direct it to where they can check it. But ideally, it would be the 5-HIA in the urine. It would be the first step to do.
Got it. Well, then I think maybe we have time for one more, which is, can you expound on what you said briefly, or what you briefly mentioned about the possibility that a liver tumor burden might cause carcinoid heart disease with a pancreatic net?
That's a very good question. So the bottom is again, and this is a good question for the oncology team. So the pathology, so the type of cells that you got in the biopsy basically drives the disease treatment and the outcomes. And of course, this whole spectrum, because that's why they call neuroendocrine tumors. They're not called like serotonin tumor or gastrin tumors or something, because they secrete more tumors than one. And this is probably going to be one of the challenges for the future is, which ones of these we block, because we cannot block them all. So that's why sometimes when we get desperate, we basically embolize that tumor. So we basically destroy the vascular supply. So then those tumor cells die and they don't secrete whatever hormone they do. The one we know, and the notorious one, is the one that the serotonin is the one that causes the valve damage, and the most one that bothers us the most. So the question for the liver mass is, how much of that liver mass is serotonin driven? And again, we can check with the levels in the urine. So then you'll know if this tumor secretes predominantly a hormone versus another one, and then we'll modify your odds of getting the valvular disease or not. So that's pretty much it. It's not, unfortunately, we do not check all the hormones that are secreted by those tumors. And it's a beautiful question. We're talking about a dozen plus of hormones that these tumors secrete. And you imagine, like, we're really in the early stages of understanding the disease right now. Despite the disease being there for, we're talking about 40, 50 years. And again, it's an initial pioneering data that's been done extensively. Right now, we're talking about, in cardio-oncology, we call it this roadmap to the next level. So we have a level we used to use, broad information. We talked about this one is like almost like looking from the airplane, where the ground level, and now we're digging in the ground to see the soil composition. So this is where you are right now. And a lot of things are happening. So it's an open question. And we'll be delighted when we will get to that one. Right now, the biggest question that we're able to, I hope, understand over the last decade is the timing of the surgery, what kind of surgery, what kind of valves, what kind of monitoring after the surgery, and then some few steps of how to treat if we see something happening with the oncology team, if the tumor burden is up, if the tumor burden is moderate, if it's down. And then with that one, we've been super excited. We could see, and there's a lot of literature out there where the mortality from the surgery dramatically decreased over the last 2 decades. And again, Mayo Clinic again leading this effort, and we were blessed. We saw a good amount. We were looking close. We're getting close to 100 surgeries as well. And we could see the pay procedure morbidity and mortality dramatically decreased, where we have lower threshold to do the surgery. But that being said, is we're talking about this monitoring, getting close to it, make sure those valves do not get deteriorated, because we have patients like the ones we mentioned in the audience, 16, 17 years with disease controlled and no effect,
Yeah.
no valve disease affected. So you don't need anything, we cannot make you better than what you are. You're fine. So I think it's a whole spectrum, and we're refining our approach and our monitoring with these hormones, the heart stretching one, the tumor, the only one we know how to measure. In fairness, like the other ones, we do not know how to measure that well either.
Got it. Well, thank you so much. That's the end of our show today, folks. I want to say, Dr. Ilescu, I appreciate you being here so much. Many people have chimed in with how great of a session this was, but I'll read one from Susan. It says, "This was a wonderful session. Thank you, Dr. Ilescu, for your expertise and willingness to answer questions." I wanted to plus one that I appreciate your time and your extra time, given our technical difficulties. Thank you so much. The people are very appreciative, and as am I.
And I said, and I always say that it's a privilege. We're privileged to serve. Again, we're privileged to have friends like you who help us have a bigger megaphone and to reach to more patients. And again, anything we can do to help anybody, we talked about this one many years ago when we went to Italy. So my philosophy, there's two different philosophies, the one, the Italian way, Renaissance one. You can see that doctors at patients' feet, we're washing your feet, okay? And that's where we're part of caring, okay? And then I'm that school. So we believe we're serving you all as good as we can.
That's
and
powerful.
There's another one when we think that after God is a doctor, and then after the doctor is the patient. And well, I'm not in that trend, and I respectfully disagree with that one. So it has to be a kind, caring approach to you all, to where we're serving you to the best of our knowledge. So again, I thank you, Rain, for the opportunity.
I appreciate you saying that last part so much. That means a lot, and I love the way that you approach that, and I think the people do too. Folks at home, we appreciate you being here. Shout out to our partners, LACNets. If you have any further questions, you can always reach us at our website, carcinoid.org, or at lacnets.org/support line. Those links are in the chat box. Thank you again to Cezar A Therapeutics and their educational grants for sponsoring this episode of Ask a Net Expert. And that's our show for today. We appreciate everybody being here. Stay healthy, stay safe, everybody. We'll see you next time. Bye-bye.
Thank you.